All right, I'm now at the humble family, England family abode. You can see my beautiful family in the background, my children's artwork, my Lego Christmas Village, the start of it anyway, that I display year round because it's my Lego Christmas Village. And honestly, at various points in this video, you will probably hear my family come in and out of the room or my dogs barking because I'm, at this point in the day, working from home. I've also had dinner now, so that's fantastic. All right, first up under fluid and electrolyte management is estimate the percent dehydration based on relevant physical exam findings. You can Google a really great table for that that will help you determine mild, moderate, or severe dehydration. The best physical exam findings in infants are going to be the fontanelle position, eyes, position sunken or normal, mouth, whether the mucous membranes look wet, or if they're sticky or dry, and then examining the genitalia. That's usually the easiest place to see skin tinting, where you pinch up the skin and see how quickly it goes back to normal. Assessing skin turgor or skin tinting is usually easiest in the genitalias. Again, mild, moderate, severe, there is a chart that should be readily available on Google for your review of that topic. 3 types of dehydration and appropriate rehydration method for each. Wow, I already said that. Mild, moderate to severe. Hold on, there's a kid talking to me. Okay, so appropriate rehydration methods. For mild dehydration, the appropriate rehydration is going to be to drink, right? It's always better if we can do a more natural remedy. So drinking electrolyte solution is going to be the best. Of the ones that are readily available in the United States, Pedialyte is going to be your best oral rehydration solution, really for any age, because it has the best balance of sugar and electrolytes in it. Gatorade has a lot more sugar in it, which can be harmful if they're having really severe diarrhea, but is a lot tastier than the Pedialyte solution is. So is a better option for the older kids and adolescents. Older than 1, they can have Gatorade. Younger than 1, then I typically ask them to get the Pedialyte solution. It's happy hour at Sonic before 10 a.m. and between the hours of 2 and 4. They can get a half-price slush. They do have the Powerade, I think, is the flavor they have there, and they're cheaper than going to the store and buying the big containers. You can get more volume for cheaper if you go there. I don't own stock in Sonic. I just happen to know that the slushes are cheaper if you go during happy hour. So I send all the sick kids there, so I'm not sure it's the best idea to go to happy hour at Sonic if you're not sick. But anyway, if you are sick, it's great. If they are severely dehydrated, if they have any cognitive impairment, then clearly you're not going to want them to drink for risk of aspiration or risk of them becoming clinical condition deteriorating progressively. So at that point in time, you would want to use IV rehydration. Remember, if you can't get an IV, you could also put in an IO or intraosseous line to provide rehydration in an emergency situation. There have been some studies looking at subcutaneous rehydration. I know they do that in animals. It has been studied in babies, but is not routinely used at this point. Calculate fluid bolus. That's what I was trying to say. Standard fluid bolus is going to be 20 mLs per kilogram. Remember, we need to use kilogram weight, so you're going to take pounds and convert that over to kilo weight. 20 mLs per kilo is going to be your standard fluid bolus. In pediatrics, we typically use normal saline to bolus. In a little bitty baby, if you're fixing blood sugar, you may use D10. In the OR, the surgeons like lactated ringers better. I don't really know why, that's just what the surgeons use. If you have a critically ill kid and you're worried about third spacing, like in sepsis or a post-op heart, you may consider using albumin. It's a little bit better at holding on to that volume. Also, if it's a critically ill child and you're worried about third spacing or cardiac function, it may be better to use a 10 per kilo or even a 5 per kilo bolus as opposed to a 20 ml per kilo bolus, which is the standard rehydration for a dehydrated kid. Cardiogenic shock, 5 or 10 ml. Cardiac source, 5 or 10 ml. Everything else, 20 ml per kilo bolus. Calculating volume deficit, there's a real fancy formula for that. Best to Google that and review. along with daily maintenance needs. Now remember the 4-2-1 rule for calculating hourly maintenance fluids rate. So for the first 10 kilos, you multiply by 4. 4 times 10 is 40, so 40 mLs an hour. For the next 10 kilos, you multiply by 2. 10 times 2 is 20. So for the first 20 kilos, they're going to get 60 mLs of fluid per hour. After that, it's a 1-to-1 ratio. So for instance, if you had a 25 kilo kid, they're going to get how much fluid? Go ahead and do the math. I'm waiting. I'm patient. You can pull out your calculator if you need to, or your smartphone. 40 plus 20 plus 5. 65 mLs per hour of fluid per hour. Remember, that's going to be your maintenance fluid rate for that patient. Max out at about 100 or 125 mLs per hour of fluid. Maintenance fluid on a kid less than 1 year of age, or those less than 10 kilos, is going to be D5 quarter normal saline plus 20 of KCl per liter. Maintenance fluid on those older than 1 year of age, or those weighing more than 10 kilos, is D5 half normal saline fluid plus 20 of KCl per liter. Now, maintenance fluids in your newborn, typically at birth, we start with 80 mLs per kilo per day. So that's calculated differently than you calculate those fluids for your patients that are, 2 months and above on the floor, admitted for various reasons. And we always start with D10 in that first 24 hours of life. We don't give any salt in that first 24 hours, just plain old D10. They're going to diurese, which is normal, pee off all that extra fluid. And then that second 24 hours of life, after that 1 day mark, we do add some salt. Usually quarter normal is about right. There's some real fancy math you can do, but it comes out to be about quarter normal. So D10 quarter normal. Saline is about right for a 2-day-old infant. Start out at 80 per kilo per day, 80 mLs per kilo per day, and go up incrementally as the child grows to about 120 mLs per kilo per day. If it's an extremely premature baby, or you expect a lot of fluid losses, like you got the old-fashioned hyperbilly lights that are really hot and warm the baby, then you may want to start with a higher fluid rate. Just depends on what you have. But hopefully you've got either you are the NICU doctor or you have a NICU doctor that can advise you if you're needing to make those kinds of decisions. Describe the impact and management of ongoing losses. Well, you need to compensate for those. So oftentimes, if a kid is having a lot of GI losses, we'll tell the parents to supplement. So every time they have a stool, you're going to want to give 2 ounces of Pedialyte, to try and keep them hydrated. And hopefully they can keep that down. If they're having a lot of stool losses while they're on IV fluids, you may want to compensate for that as well. Hopefully orally if you can, and if they can't tolerate that, then via the IV. But you can measure those if they're in the hospital and make sure that you're accommodating for that in their IV fluids properly. Understand the management of septic shock in patients. In septic shock, they can third space. So you may need to use different fluids, albumin being a very common one, to help pull those fluids in. But fluid management is definitely critically important. Also making sure that you prevent hypotension and keep critical organs perfused with the use of various pressors, epi, dopamine, depending on the situation. But fluid management is really important in shock, and making sure that you're paying attention to third spacing and maintaining intravascular volume is really important. Looks like that's the end of this learning objective. Excellent.